Sir, good evening, Dr. Matthew.
Yeah. Good evening, sir. Good evening,
Good
sir.
evening, Sanu. How are you?
Fine, sir. How are you, sir?
Fine, fine, fine.
Thank you,
So
sir.
the
Nice.
speakers are there, they can check their slides.
Okay, okay. Let's see. Meeting starts again. Yeah, anybody can um, test their slides.
Hi, sir.
Hi, Edmund. How are you?
Hi,
Okay.
Edmund.
Hi, Sanu.
Good evening, Edmund. How are you?
All good.
Yeah, long time since we saw each other.
Yeah. Can I test the slide?
Yeah, please.
Yeah. Yes, sir.
Sir, am I audible?
Yes.
Are my slides visible, sir?
Yes, visible, Edmund.
Are the slides moving, sir?
Yeah, moving.
All right.
I'm
stopping the share.
Hi, Dr. Sumit.
Hello, sir. Hi.
Hi,
How
Sumit.
are you,
Good
sir?
evening.
Hi,
Hello,
sir.
everyone. Hello, everyone.
Good evening, sir.
Hello, everyone. Hi, colleagues.
Hi, Sumit. Hi, good evening.
Hi, sir. Hello, Anil. Hi.
Hi, Anil.
Good evening, Sumit, sir.
Hi, Panu. Hi. Good
Thank
evening.
you, sir. Good evening. Good evening, Anil Kumar, sir.
Good evening.
Hi, Anil.
Hi, sir. Good evening, sir.
I think it's 4. We'll start. Shall we start? Matthew, sir?
The other speakers, Dr. Akshay Hari, Dr. Nilay, Dr. Umesh, are they available, sir, now? Are they online?
Sanu,
Doctor-
just remind them.
Yeah, already sent the link to them. I'll just call. Hello, Dr. Akshay, are you ready? Pardon me? Okay. Oh. Dr. Akshay will be ready in 5 minutes, he said. I'll call.
Okay.
Am I audible?
Yes, yes.
All the other speakers will be joining in a few minutes, sir. I called them up.
So are we going to start in some time? So
Yes, sir. In 2 minutes, I think. In 2 minutes, we can start.
Dr. Salu, I think we can start.
Okay, sir.
We can start.
Okay. So, good evening, all. I'm myself, Dr. Sanu Vijayan. I'm a consultant neurosurgeon and a spine surgery specialist working at NSI Hospital, Ernakulam, Kerala. And I'm really honored to serve as the coordinator for today's webinar. So, as we know, the topic for today's discussion is spondylolisthesis. Although it is a very common condition in clinical practice and the diagnosis is often straightforward, the management decisions can often be challenging. As clinicians, we frequently face uncertainties regarding when to treat conservatively versus surgically, as well as the choice and the timing of surgical intervention, making the treatment strategies nuanced and individualized. So, today's discussion aims to clarify these gray zones, simplify decision-making pathways, and explore modern surgical strategies and help us to navigate the complexities of managing this situation and delivering the best possible outcome for our patients. So our today's session will cover all the key aspects of spondylolisthesis from natural history, classification to advanced minimally invasive surgical techniques and robotics. The session will consist of 4 talks with each speaker allotted 20 minutes for their presentation. I now have the privilege of introducing our moderators for today's session. First, I would like to welcome Dr. Anil Kumar Sharma. Dr. Anil Kumar Sharma is currently the head of the Department of Neurosurgery at AIIMS Raipur. He was trained as a visiting fellow in spine surgery at the Medical College of Wisconsin in 2019. Dr. Anil Kumar Sharma served as the chairman of a Young Neurosurgical Forum, NSI, from 2024 to 2027. He served as an executive council member of the Cerebrovascular Society of India from 2022 to 2024. He is a prolific researcher with nearly 60 publications and is actively involved in mentoring young neurosurgeons. He also serves in the executive committees of several national neurotrauma and microneurosurgery societies. Dr. Anil Kumar Sharma, we welcome you and thank you so much for being with us today.
Thank you.
Now, I would like to welcome Dr. Kodishwaran who is a professor and head of the Department of Neurosurgery at Kilpauk Medical College, Chennai. He serves as an executive committee member of the Neurological Society of India, as well as the Tamil Nadu Association of Neurological Surgeons, and is also the convener of the webinar committee of the Neurological Society of India. He has published extensively and has been in the forefront of organizing academic meetings and educational activities across the country. Welcome, sir, and thank you for joining us today and for moderating this session. Finally, I would like to welcome Dr. Matthew Abraham, an eminent neurosurgeon with extensive academic and clinical experience. And he's currently working as the head of the Department of Neurosurgery at NSI Hospital, Ernakulam. He finished his MCS neurosurgery training from the Sri Chitra Institute, Trivandrum, Kerala. He served as a faculty at Sri Chitra Institute from 2003 and later became head of the department in 2017 before taking over the leadership at NSI Hospital in 2022. His special interests include epilepsy, vascular, skull-based neurosurgery, and has published more than 90 papers in peer-reviewed journals. Also, he has been invited speaker for over 200 national and international conferences and has conducted more than 15 operative workshops. Welcome, sir, and thank you for joining us this evening for this webinar. Now, I would like to invite the moderators to kindly introduce the panelists for our session today.
Yeah. Thank you, Dr. Sanu. It's my privilege to introduce Professor Sajis Menon. Am I audible?
Yes, yes,
Yeah.
yes, sir.
Professor Sajis is a highly distinguished
You are
neurosurgeon,
audible.
spine specialist based in Kerala and working as professor and head of the department at Amrita Kochi. And his clinical interests include minimally invasive spine surgery, motion preservation technologies, craniovertebral junction, spine trauma, and endoscopic spine surgery. And he has played a key role in establishing neurospine and peripheral nerve surgery program at Amrita Institute of Medical Sciences. And he has several leadership roles, including president of Neurospinal Association from 2019 to 2021, and active and engaging faculty member of AO Spine India. So I welcome him on the board as panelist. And I will request Professor Kodiswaran to introduce Dr. Somesh Sinha.
Good evening, everyone. This is a great pleasure to introduce my friend, Dr. Sumit Sinha, who has completed his training in All India Institute of Medical Sciences, and he served in AIMS for 15 years and he was promoted as Professor of Neurosurgery in 2016. Now he is the Principal Director of Robotics and Minimally Invasive Neurosurgery and Spine Surgery at Max Hospital, Gurugram and Dwaraka. Is an all-rounder neurosurgeon, accomplished spine, brachial plexus, and peripheral nerve neurosurgeon. He is a AO Spine International faculty member. Previously served as AO India Education Officer for Neurosurgery Spine from 2019 to 22. And also he has multiple leadership positions like Treasurer of NSI and President of NTSI and Secretary of NESI. And Sinha has more than 200 publications, multiple book chapters, and neurosurgical books to his credit. And he played a key role in developing national guidelines for traumatic brain injury and establishing cadaveric training in All India Institute of Medical Sciences. I welcome Dr. Sumit Sinha.
Thank you, sir. I would like to invite the moderators to kindly introduce and invite the speakers for their sessions.
Yeah, so our first speaker is Dr. Akshay Hari. So he's a consultant neuro and spine surgeon at Esther CMI Hospital, Bangalore, with over 1.5 decade of experience. And he previously has been associated with Royal Melbourne Hospital and at the spine surgery program at UCSF, California. And he specialized in minimally invasive and complex spine surgery, including deformity correction and robotic techniques. And today he will be speaking on natural history, classification, and spinopelvic alignment. Dr. Akshay Hari.
It's an honor to introduce Dr. Edmund Jonathan. Edmund is a professor of neurosurgery at Christian Medical College, Unit 3, and he was a fellow of Royal College of Surgeons of England. And he had multiple fellowships from University of Pittsburgh, also from South Korea. He specialized from endoscopic skull-base surgery and UBE, and also complex vascular bypass. Is a prolific researcher with over 50 peer-reviewed publications, with the recipient of Bharat Jyoti Award. Today, he's going to talk about low-grade spondylolisthesis and management, including parts repair. I welcome Dr. Edmund Jonathan.
Thank you, sir.
I welcome Dr. Matthew to introduce Dr. Nilay Biswas. Dr. Matthew. Dr. Matthew is there?
Am I audible?
Yes.
Am I
Yes.
audible?
Yes.
Yes, sir. Yes, sir. You are audible.
Okay. Dr. Neeloy Biswas is a neurosurgeon. Basically, he's from Calcutta. He completed his MBBS and MS from Medical College, Calcutta. He obtained his MRCS from Royal College of Surgeons, England. And later, he got his MCH in neurosurgery from the Bangalore Institute of Neurosciences. He has undergone advanced training in microneurosurgery from AIMS and also advanced neurosurgery fellowship from the PD Hinduja National Hospital, Mumbai. He took the AO spine principal course training in advanced spine surgery held in Ahmedabad in 2013. His clinical interests include complex spine and microneurosurgery. He will be today speaking on high-grade spondylosis, including high dysplastic type and indications for these procedures. I welcome him to this meeting.
Thank you, sir.
So our last speaker is Dr. Umesh Srikanta. It's my pleasure to introduce him. He's working as additional director of neurosurgery and lead spine surgeon at Fortis Hospital, Bangalore. We are from same alma mater, Nimhans. He completed his fellowship in minimally invasive spine surgery in South Korea, and he does mainly 80% of his practice dedicated to MIS techniques, including endoscopic disc surgery under local anesthesia and 3D navigation guided procedures. So he will be speaking on MIS and spondylolisthesis challenges and future. Welcome, Dr. Umesh Srikanta.
Thank you. Thank you. Glad to be here.
So I think, can we start our first session?
Yes.
Yes.
Dr. Akshay
First
Hari.
speaker.
Hello everyone, I'm Dr. Akshay. Thank you very much once again for inviting me. I hope I'm audible.
Yeah, you're audible. You're audible, Dr. Akshay.
Yeah. So I hope my screen is being shared.
Your screen is visible. Your screen is visible.
All right. So my first topic for the day is going to be on the classification and basic explanation of the anatomy, that is spinopelvic alignment as well, and then brief history about the brief description about the natural history. So we all know that spondylolisthesis basically what it means is there's a translation of one vertebra on the adjacent segment in the sagittal plane. It can be either an anterior translation, anterolisthesis, or a retrolisthesis. By that means a posterior translation. It basically spondylolisthesis is derived from the Greek word spondylos, which means the spine, and olisthesis, which means to slip. And so briefly, the evolution of the description of spondylolisthesis began way back in the 1700s, where it was described as by Herbinox et al. as a prominence in front of the sacrum, and subsequently it has various iterations of spondylolisthesis has evolved in the history. So as latest as in 1963, that's when the first classification realize that there needs to be a classification for this type of spondylolisthesis. So before we go into that, I would just like to describe what the exact anatomy in the lumbar spine and where spondylolisthesis, and basically the important anatomy as far as spondylolisthesis is concerned. So first of all, the pars interarticularis, this plays a very, very important role as far as spondylolisthesis is concerned. This is the region between the superior and inferior articulating facet of the vertebra, and it is actually the weakest area in the neural arch, and it is susceptible to stress fractures. So this is where the anatomy of the pars is As you can see on the oblique X-ray, it is classically described as the Scottish dog appearance, wherein the neck is actually, the neck of the Scottish dog is actually the pars, the eye is the pedicle, the nose is the transverse process, the ears are the superior articular facet, and the forelegs are the inferior articular facet, and the hind legs are actually the spinous process. So this is traditionally how the spinal X-rays were viewed, to basically understand where the defect in the pars was there. And that was actually the collar. If there was a pars defect, that's what was understood as the collar of the Scottish dog. And also the embryology, briefly touching upon that, is that the pars basically ossifies at between 12 to 13 weeks of gestation via enchondral ossification. And in the lumbar vertebrae, basically the ossification center in the region of the pars there's a lot of uneven trabeculation and cortication as well, whereas the ossification center that arises at the upper end of the pedicle has a uniform trabeculation. So this is a potential for a stress which can occur, which can be susceptible to fatigue fractures. The another anatomy important thing is the facet joints. In the coronal plane, basically the facet joints consist of the inferior articular process, there is the upper, from the upper vertebra located posteriorly, and the superior articular process which is located anteriorly, which arises from the lower body. This prevents the forward movement and basically locks the superior vertebra relative to the inferior vertebra. Also, the orientation of the facet is very important. And viewed from the superiorly, basically these are biplanar. General orientation is around 45 degrees from the sagittal or the frontal plane, and sometimes it can be 90 degrees from the transverse plane as well. So these are supposed to resist the anterior shear in the anterior aspect and resist rotation, that is in the posterior aspect in the sagittal plane. Also, another important, there is a global anatomy. The center of gravity of the human body is anterior to the spine, and it exerts a forward slipping force on the spine, especially that is the last L5S1 disc space. And the anteriorly located center of gravity that can actually cause a rotating movement with the axis of rotation oriented transversely at the L5S1 level. And in severe spondylosis, bifurcating deformity also.
Attention, please.
So the pars defect basically is not observed in newborns or in non-ambulatory patients. For that, I'm sitting in the hospital, so there's actually an announcement.
Please come to main entrance parking area immediately.
I'm very sorry for that inconvenience. There was a announcement in the hospital. So I resume. So basically, pars defects are not observed in newborns or in non-ambulatory patients, and this is because of the lumbar lordosis that is unique to the humans, which is necessary for our erect posture. So the concept is basically a hook and catch concept, which is what the traditionally described spondylolisthesis is. Basically, the hook is the pedicle or the pars intra-articularis, and that is the inferior process of the cephalad level, and the catch is basically the superior process of the cephalad of the caudal level. So any disruption in this hook and the catch mechanism is basically what leads to the spondylolisthesis. Only locking of the posterior facets, intact neural arch and pedicle, normal bone plasticity, these are all necessary, and even the working of the normal working of the intervertebral discs. Any breakdown of this normal locking mechanism leads to the articular defects and the defects in the neural arch, which leads to spondylolisthesis. These are the various theories. I think I'll not go into this details, and basically now we know that the etiology is multifactorial. There may be a congenital predisposition, but there are a lot of biomechanical factors as well which are playing. So the current consensus is this, that there are both local and global anatomic factors which act as the trigger. So that is why the necessity for a classification system is basically very important. These were the various classifications which have originated. The anatomical classification, etiological, was described by Wilson, Newman and McNabb. The Meerding classification, which is very essential, that is used regularly for recognizing the degree of slip. And then the Marchetti and the Bartolozzi classification, which is divided basically into developmental and dysplastic types. And the most recent classification is the SDSG, or the Spinal Deformity Study Group classification, which takes into consideration the global alignment as well. So this is the first classification, that is Wilson, Newman and McNabb classification, divides spondylolisthesis into 6 types, that is congenital, ischemic, which are having 3 subtypes, degenerative, traumatic, pathologic or iatrogenic. So the first type, that is dysplastic. This is what you can understand here. There are no pars intra-articularis defect is present. There is because of a congenital abnormality of the sacral dome. And the second thing is the isthmic, which has got 3 subtypes. I'll go into this in further detail. So the first type, that is dysplastic type, is mostly is seen in about 20% of the population. It occurs usually at the L5S1 level. There is a congenital dysplasia or dysplasia of the L5S1 facet joints. That is, the inferior facet is dysplastic and the sacral facet is usually absent. There is no pars intraarticularis defect that is present and is frequently, in fact, even associated with spina bifida occulta of the L5 and the sacrum. It is more common in females, and sometimes there can also be an elongation of the pars, and that may also lead to frank lysis. In lateral radiographs, you can see that there is a dome-shaped view of the sacral of the sacrum, and in AP view you can see that there is an actually superimposition of the L5 over the sacrum, also commonly described as the Napoleon's hat. So the etiology, basically, how this develops is basically there are once again various theories which have been described by we'll say Lett as well as Creon. But the consensus nowadays is that the pathophysiology, there are 2 pathways. Either it can be a dysplastic pathway or a traumatic pathway. So in the dysplastic pathway, there is because of a congenital abnormality in the development of the lumbar facets, lumbosacral facets. There's a weakness. There's a predisposed weakness in the hook and catch mechanism. The body weight over a period of years is transmitted through this weak zone. The soft tissue restraints which are there congenitally, which are helping also wear out over a period of time, and the growth plate itself is overloaded. The traumatic pathway is that there are, because of repetitive cyclical loads which is there, especially in the case of sports or wherever there are injuries day to day, there is also stress fractures of normal parts. The hard cortical pars which is there, which is also predisposes to the fatigue fracture and non-union, ultimately leads to a vertical subluxation. So once again, just a brief description of how this pathway actually happens. Initially, there is a congenital malformation, that is, the bony hook and catch mechanism is lost. The L5 is unable to resist or prevent the anterior forces which are there because of the global, like I said, the plumb line which is not going through the sacrum. There is a plastic deformation which is occurring at the level of the disc space, as well as the failure of the posterior and anterior ligamentum complex, which ultimately leads to subluxation of the vertebra. So with the continuous growth, they lose their ability to resist anteriorly directed forces, and this leads to a slippage. So what are the changes that are seen in the X-ray? You can make out that there is a sacral rounding of the proximal head. That L5 itself is trapezoid in shape. This leads to a vertical sacrum, and sometimes there can be junctional kyphosis as well, and there may be a compensatory hyperlordosis. See, in the traumatic pathway, basically the center of gravity, like I said, is primarily anterior to the lumbosacral joint, and this leads to a forward force. Once again, as I mentioned earlier, repetitive cyclic loading is happening, and the resistance of the parts which is there initially leads to a fatigue failure, and that is not able to resist the anterior forces. So whatever fibrous tissue which forms, even that is not able to sustain anterior forces, and this leads to shear stress at the level of the disc as well, and this leads to a vertebral subluxation. The second type, that is almost 50% of this is isthmic type. Now here there is a actual defect in the pars intraarticularis that allows a forward slippage of the L5 over the S1, and there are 3 subtypes. One is the lytic subtype, which causes a stress fracture of the pars intraarticularis. The second type, there may be multiple attempts at healing, which leads to an intact but elongated pars. And the last one is an acute fracture of the pars intraarticularis due to high energy injury. So because of the repetitive cyclical extension or torsion of the spine, there is the fatigue fracture of the pars which happens, and this also leads to high biomechanical forces at the L5S1 level. So once again, that is the most commonest type of the lytic listhesis or isthmic listhesis. As you can see in the X-ray, you can make out that there is a clear lysis at the level of the pars. So the etiology in this case, because of the it is due to upright working weight bearing, like I told you, it is because of the erect posture, one of the drawbacks which happens, and it is seen in more common in males than in females. And because of repetitive sports injuries, this is more common commonly in sport persons as well. So once again, this is the pathway of how this repetitive fractures of the pars can lead to ultimately inability of the anatomical structures to bear the anterior shear forces, and once again leads to a vertebral subluxation. The third type is the degenerative type. This is seen more commonly in elderly and or adults age group more than 40 to 50 years. This is seen more commonly in L4, L5 rather than L5. And studies have shown that it is once again seen more common in women than in men, and there is a progressive spondylolisthesis that occurs in almost 34% of the cases, wherein further disc space narrowing occurs with once again leading to so here more than the pars defect, there is because of the incompetence of the posterior facet joints. That is because of a degenerative changes which take place. So here the time is important. That is, the degenerative process keeps going on for years and years, and the patients are able to readily adapt. That's why sometimes you may find that there are even higher grades of listhesis. Most of the times there may be more of pain. Patients come with more of pain because of degeneration rather than neural compression. So this is the degenerative cascade just proposed by corrective. So what is that stage of dysfunction which leads to disc degeneration as well, maybe even disc herniation? Then it leads to a stage of instability. This is the time where there is a subluxation and leads to nerve compression. And ultimately, it may lead to a single level, which may even progress to multiple levels. So here what the pathway is that the facet degeneration is the first to take place. Because of that, there is no resistance for the anterior translation. That is because the neural arch is once again destroyed because of the facet degeneration, and here that leads to a predilection for the slippage. Initially, if the disc space is good, and so there may be a resistance from the anterior subluxation, but over a period of time, even when the disc degenerates, so the anterior subluxation also happens. So coming to the traumatic spondylolisthesis, here not occurring at the level of the pars, but probably at the level of the pedicles or the bodies of the discs. This is why it is called as traumatic listhesis, and it does not come under the ischemic type. The fifth one is the pathological spondylolisthesis, which may occur because of a result of metastasis or rheumatoid disease, occurs at the level of the bone. Lastly is the post-surgical or the so traumatic, like I said, because of any high energy trauma, usually motor vehicle accidents, there is a fracture of the bony hook other than the pars. Pedicles may also lead to a
Seems we have lost, sir.
Am I audible now?
Yeah, you're again visible.
Okay. So this is the sixth type, that is the iatrogenic type. So coming to the next type of classification, that is the Marchetti and the Bartolozzi classification. Here they divided the spondylosis into two types, that is developmental and acquired. What this is based on the etiology. It distinguishes between the acquired and developmental forms. This is most relevant to the natural history and risk of progression and implications in the treatment. So they divided also they brought in the concept of high and low grade developmental spondylosis, and this permits the early recognition and the treatment. So the acquired spondylosis can be because of a trauma, can be because of surgery, can be because of a local pathology, degenerative or secondary. Developmental is because of the dysplastic, which can be high dysplastic or a low dysplastic. So this is where the concept of low grade listhesis and high grade listhesis came into being, but they had not classified further into various subtypes. So that's the next classification is the Mayer-Dean classification. This is dividing these type of spondylolisthesis into 5 types. That is, once again, grade 1, which is less than 25%, grade 2, which is 25 to 50%, grade 3 between 50 to 75%, grade 4 more than 75%, grade 5 spondylolisthesis, that is complete L5 displaced anterior beyond the sacrum. So these are the various types. This is more of a radiological classification. So there was one more modification of this grading system. So that is called modified numeric classification. What they did is that they were able to define the amount of anterior roll of L5 over S1. So what they've done is basically they created a numerical system and they divided the entire sacral dome into 10 segments, and then they have classified the degree slip based on that. Coming to the last classification, that is the SDSG classification. So what was done here is that the L5S1, specifically L5S1 spondylolisthesis, was graded into two types, that is low grade or the high grade spondylolisthesis, and further the low grade were divided into three types, that is type 1 where the pelvic incidence was less than 45 degrees, the type 2 where the pelvic incidence was between 45 to 60 degrees, type 3 where the pelvic incidence was more than 60 degrees. Then came the high grade spondylosis, where that is type 4 and type 5, where the type 4 is basically a balanced pelvis, and type 5 and type 6 were retroverted pelvis, balanced and unbalanced. So to understand this, basically we need to have an understanding of the spinal parameters which are actually there, that is the spinal alignment parameters. So basically the reason for this is that we needed a more comprehensive classification for the spondylolisthesis, and that's why in 2006 McTheon et al. Developed this classification. So the initial parameters were basically the slip grade, spinopelvic alignment, and the bony dysplasia. However, that was later on related to 2009. I'm extremely sorry. I think there was some once again disconnection. Am I audible once again now?
You're audible, sir.
Yeah, you're audible again.
You're audible now.
Right, I'm very sorry for that. So then here the next concept is the understanding of the pelvis, the role that the pelvis also is playing. That there are two types of pelvis, that is a retroverted pelvis and antiverted pelvis. So what the different type of pelvis also plays a role in the type of this the spondylolisthesis progression. So what we need to understand is that in low grade spondylolisthesis, that is the type 1, that is also known as the nutcracker group, was that there is an inherent low PI, and that also has a role in the progression of the spondylolisthesis. Type 2 is a subgroup with normal PI. Type 3, there is a shear type, that is a grade with a high grade. So these patients had a higher predilection for the progression of the spondylolisthesis. Even in high grade spondylolisthesis, it needs to be further classified as a balanced and unbalanced pelvis. Now that plays a role in the progression of listhesis and the kind of treatment that needs to be initiated. So basically the SDSG classification as per Meyerding, that is the type 1, 2 and 3, they were low grade, whereas type 4, 5 and 6 were considered as the high grade. So this is the type of the pelvis that was, this is the type of the slips that I just described over here, based on the dysplasia. And high. So now we need to understand what the role of anatomy and biomechanics plays in basically having a thorough understanding of how spondylolisthesis can actually progress and what kind of treatment needs to be initiated. So it's not just the local anatomy or the local listhesis at whether it's L4, 5 or L5 or so. There's a global sagittal plane alignment is also that is very, very important to be considered in both adult as well as pediatric patients with spondylolisthesis. That is, in the coronal plane, the plumb line that is dropped from the dens should fall normally through the center of the sacrum, and in the sagittal plane, the plumb line through the C7 vertebral body should pass anterior to the thoracic spine and posterior to the lumbar spine through the body of the S1. So even though there may be a local deformity, it may have a regional deformity only at the level of the lumbosacral or pelvic level, but it may actually lead to an entire spinopelvic deformity leading to a global deformity. Now this is very, very important to be understood. And so what are the factors, local factors that are governing this lumbosacral dysplasia is that there may be a lumbosacral kyphosis, if there is a trapezoid lumbosacral junction, lumbar segment. If there is a sacral dysplasia as well as kyphosis, there may be a bifid posterior arch, hypoplastic or aplastic facet joints. Basically, all of the reasons that have been mentioned before in the various classifications. So there are certain important radiological parameters that we must understand. Now is the slip angle that is measured from the superior part of the L5 and a perpendicular line from the posterior edge of the sacrum. If an angle is greater than 45 degrees, it is understood that there may be a greater risk of the slip progression, instability, and the development of pseudoarthrosis. This is what was described as the slip angle by Boxall et al., and this is how it is measured basically between the slipped vertebrae. And it is actually the best predictor of the progression of the slip. The next very important parameters are the pelvic tilt and the sacral slope. So the pelvic tilt, this is what determines the retroverted or anteverted pelvis. So this is a very important radiological parameter, that is a line that is drawn from the midpoint of the sacral end plate to the center of the femoral heads, and the angle that this line subtends by with a vertical reference line. This is known as the pelvic tilt. A higher pelvic tilt also predisposes to a greater amount of to progression of the spondylolisthesis. The next important thing is the sacral slope. Once again, the sacral slope is also a determinant of the type of the pelvis, whether the pelvis is a horizontal or vertical pelvis. So a line that is parallel to the sacral end plate is drawn, and this line, the angle that is subtended by this line between that and the horizontal reference line is known as the sacral slope. So vertical sacrum, that is sacral slope more than 100 degrees, is also a high risk for progression of the slippage. Then comes the pelvic incidence, which is nowadays the most important parameter for determining what kind of surgery that needs to be performed, or how much or what kind of surgery that needs to be, or how much degree of reduction that needs to be achieved. So pelvic incidence is basically it is a sum of the pelvic tilt and sacral slope. That is, PI is equal to PT plus SS. This is considered as a uniform standard for every patient, and that does not change no matter whatever type of the pelvis is there. So this is a constant. So the pelvic incidence is also measured on the on the X-rays by a line that is perpendicular to the midpoint of the sacral end plate that is drawn, and a second line that is connecting the same midpoint to the midpoint of the femoral heads. Now this angle that is subtended between these two imaginary lines is considered as the pelvic incidence, and the normal pelvic incidence is roughly around 50 degrees, maybe the range between 40 to 60 degrees, and it is unaffected by posture, and an increased PI may also predispose to the greater risk of spondylolisthesis progression. Next comes the concept of the balanced versus the unbalanced pelvis. So a balanced pelvis is where the compensatory increased lumbar lordosis. Now here is another important parameter, that is the lumbar lordosis. This is also known as the Cobb's angle. This is the angle that is measured between the superior end plate of the sacrum as well as the superior end plate of the L1, and this is also, the calculation is known as that is a pelvic incidence. Rather, the lumbar lordosis should be within 10 degrees of the actual pelvic incidence. Any increase or decrease in the lumbar lordosis may be conversely affected with an increase in the progression of the spondylolisthesis. So what is considered as balanced pelvis is that where the lumbar lordosis is almost roughly equal within 10 comes within 10 degrees of the pelvic incidence. An unbalanced or a retroverted pelvis is where there is a high PI, and because of a high PI or an increased pelvic tilt, that is there is a hyperlordosis of the lumbar segment and as a compensatory mechanism, and in such cases, because of a high shear stress at the level of the facet joint, there is a progression of the spondylolisthesis that can occur. And in an unbalanced spine, the C7 plumb line falls anterior to the femoral heads. This is because of a lack of compensatory or a failure of the compensatory mechanisms that are already there in the lumbar levels. So then another important thing is the criteria of the instability that is mentioned by White and Punjabi. As we know, in between flexion and extension radiographs, what is considered as a stable listhesis or an unstable listhesis, that is the sagittal plane translation and the sagittal plane rotation. This is something that also needs to be considered during our calculations. Lastly is the sacropelvic alignment. Like I had said, that is in the balanced group is usually the patients may have a low pelvic tilt and a high sacral slope. That is, in the calculation bit of the PI, the sacral slope is where it plays the predominant role and not the pelvic tilt. In the unbalanced group, these are the patients who generally have a retroverted pelvis and they have a higher PT as compared to the sacral slope, and even though if they have a normal PI. So it has been shown that patients with a high degree of vertebral slippage may have a PI greater than 60 degrees, and this is associated with a naturally an increase in the lumbar lordosis as well, which leads to mechanical changes at the level of the lumbosacral junction, which increases the risk of the spondylolisthesis. And ultimately, the global, like I mentioned, this plays a role in the global spinopelvic alignment as well. This is known as the sagittal balance. So that is, the spinopelvic balance is determined by the use of the C7 plumb line. So the C7 plumb line should fall in front, like I already mentioned, should fall at the level of, should pass through the superior border, anterior border of the S1, or at least within 2 centimeters. So if it is falling much ahead, so that also leads to an unbalanced pelvis. This is known as the SVA. So if the SVA is very, very high, so now these are the various types as per the SDSG classification. So the various types of, that is the type 1, which is the nutcracker pelvis, and the type 2, which is having a normal PI. Type 3 is a very high PI. Type 4, 5, 6 are high grade listhesis, that is 4 is in a balanced pelvis, 5 is a retroverted pelvis, and 6 is a completely unbalanced spine. As you can see, all the parameters are completely off balance. There is a high PT, there is a C7 plumb line is also off balance, that is a very high SVA. So all natural history. So what are the risk factors for the progression? If there is a younger age at presentation, if there is a female gender, a slip angle of more than 10 degrees, a high grade slip, if there is a dome shaped or a significantly inclined sacrum, these have a higher risk of progression. So the natural history is predominantly determined by the developmental or the acquired spondylolisthesis, low or high dysplasia, quality of the pedicle, pars and the facet joints, the age at which the diagnosis is made, the degree of lordosis and the position of the C7 plumb line, the degree of secondary or remodeled deformity, and the competency or the hydration and the height of the disc as well. So if it is a dysplastic spondylolisthesis, there is a higher risk of this slip progression. If there is a degenerative spondylolisthesis, which is rare before 50, these are also once again there are because of the patients more have a greater risk of back pain other than the neurological deficits, and that's how they predominantly present. Anyway, thank you for your kind attention. So this brings to the end of my topic. I hope I was able to shed some light on the various biomechanical parameters.
Thank you, Dr. Akshay Hari, for your excellent presentation. It is really nice. You have addressed all the aspects of the different grades of dysplasia, the classification in detail. Thank you so much. Now I think we can, it's time to invite our second honorable speaker. I would like to invite Dr. Edmund Jonathan to present this topic.
Thank you, Sanu. Thank you for the moderators and the panelists for giving this opportunity. Topic of discussion today is on management of low-grade lumbar sacral spondylolisthesis. My previous speaker, Akshay, had shed light on the natural history and the pelvic alignments. That makes the talk easier. I'd like to acknowledge Dr. Bashir for having helped me with this presentation. We all know that lumbar listhesis is a disease of elderly, and its prevalence is increasing over the decades. As the longevity increases, there is increase in lumbar listhesis. It's female predominant, and we all know it's one of the common indication for lumbar spine surgery. We read the pathophysiology. It's because of disc degeneration, facet joint arthropathy, ligamentum flavum hypertrophy, and segmental instability with canal stenosis that results in the lumbar spondylolisthesis. How do we evaluate? The most common is standing X-rays. We look for the Meyding's slip grade, and we also look for flexion extension to assess the instability, MRI to study the canal stenosis and nerve compression. We also look carefully for facet effusion that may predict instability. As soon as we see a patient with a lumbar listhesis, the first way to go about is to give them a non-operative management, ask them to modify the activity, give them a short course of NSAIDs and analgesics, offer them physical therapy, and a brief epidural steroid injection. However, it is debatable on the role of steroids. What are the indications for surgery if there is persistent symptoms even after conservative trial, and neurogenic claudication is affecting the quality of life, and if there is any evidence of progressive neurological deficit, and that correlates radiologically and clinical, that helps in coming to the making a diagnosis and also provide him the indication for the surgery. There is always a core dilemma in this. Is relieving neurological compression sufficient, or do we need to recommend fusion for the destabilized segment? That's the topic of discussion today, and we will go through it. The NAS guidelines defines the translation increase in slip of greater than 3 mm on dynamic X-rays, an increase in the segmental angle by greater than 10 mm when bending forward as a sign of radiographic instability. Surgeon views on defining instability are highly variable. So there is a paradigm shift in the instability spectrum. Gross dynamic instability requires fusion, but stable slips and minor dynamic micromotion often do not. The traditional markers, we have gone through this. Also, we are stressed about the segmental angulation. What is the surgical dilemma? There are two paradigms of care. One talking about only decompression, where we remove the bone and lamina and ligamentum flavum and free the nerve roots. The argument for this is that it is less invasive and it preserves natural anatomy and avoids implant-related complication. But the concern, excessive removing of the facet can accelerate or induce postoperative instability at the index level. Whereas decompression with instrumented fusion is for neural relief on rigid segmental stabilization. The argument for this is it prevents further slippage and addresses mechanical back pain and provides permanent mechanical solution. However, there is increased morbidity, blood loss, cost, and adjacent segment disease. What are the arguments for fusion? The trial that was done by Gogwala et al. In 2016, published in NAGM on it's a slip trial, where they found that there was statistically difference in the fusion group in the SF36 and ODI. So the SF36 and ODI scores radically improve from baseline across the major trials, regardless of the intervention. The surgery is highly effective. And the debate is no longer whether to operate, but determining if hardware provides a statistical and clinical significant long-term advantage is something which we need to look at. Whereas this trial that has come out in 2021 and in 2023 as from the Norwegian group, they demonstrate, they conclude that decompression alone is non-inferior to fusion. As seen here, they have achieved comparable success between the fusion and the decompression group. Non-inferiority firmly established in a modern surgical cohort in a 2021 trial, and they felt that decompression alone is sufficient as compared to decompression plus fusion. Similarly, meta-analysis has concluded that satisfaction between decompressed patients and those with stenosis alone, decompression plays a major role. This is also a latest analysis which is in more favor for a decompression. What are the physiological and operation toll that happens? In decompression, we see that in slip trial, the time taken is almost close to 124 minutes, and time taken for decompression is close to 104 minutes. This is significantly higher in the fusion group. Intraoperative blood loss is also significantly higher in the fusion group. The length of hospital stay also differs between the decompression and the fusion group. What is the clinical takeaway from this? A fusion represents a massive expansion of the surgical footprint, making it potentially unsuitable for medically fragile or elderly patients. When we compare the reoperation rates in the decompression group, it's quite high. In slip trial, it was close to 34, whereas it was 14% in fusion. And then the important thing to note here is that all decompression reoperations were at the index level instability. Whereas there was not significant difference in the Norwegian trial, whereas it was 12.5 and 9.1. The dural tears also were comparable. It was slightly higher on the fusion group, The adverse events were comparable between the fusion and the non-fusion. So when we take the decompression pathway, what is the thing that we look at? The SLIP trial has shown that there is a cumulative reoperation risk at 4 years, entirely driven at the index level. If you look at the fusion path, there is a biomechanical failure. SIP trial showed that there is 14% reoperation risk at 4 years because of adjacent segment disease or hot wave failure. Reoperation risk is time dependent. So what are the things that we look at when we look at the patient who had undergone fusion? It is the adjacent segment disease. Reoperations are frequently driven by adjacent segment disease and implant failure. And their study on the latest study of meta-analysis that had showed about the adverse events has seen that the fusion group had almost 12.8% minor events, major events 4.5%. They both were comparable. Decompression failure was typically due to recurrent stenosis or instability, whereas fusion failure was due to the adjacent segment disease. So is there a role of obesity that results in failure? Not. The study had shown that patients with a BMI greater than 30 was not statistical risk factor for reoperation. Reoperation was almost comparable and the p-value was not significant. So the decision to fuse should be based on anatomical and biomechanical factors like pelvic incidence and lumbar lordosis, mismatch and facet orientation, and it should not be based on patient weight or BMI. What's the role of MIS? We all know that MIS is taking up in a big way. It helps in decreasing the hospital stay, decreased infection, and has a good prompts at the end of 2 years. So we know that the incision and the tissue damage is less in MIS and facilitates rapid discharge as compared to the open, and it reduces the surgical site infection. So when you have a low-grade stable listhesis, better is to go for decompression, which is optimal. If there is evidence of dynamic instability, better to go for fusion. So what is the role of spinopelvic alignment in defining the anatomy of instability? We have seen through the previous talk about pelvic incidence and sacral slope, which plays a major role in determining the instability. So when there is a PI and LL mismatch greater than 10, it indicates higher risk of postoperative progression. So this would be the main decision matrix. If you have a grade 1 degenerative spondylolisthesis and you have an alignment that is PI and ALL, and it is a single level and leg pain dominant, note it is a leg pain dominant, stable on dynamic imaging, he is an ideal candidate for decompression. But if you have greater than 3 mm translation and mechanical back pain is dominant and there is a high PI-LL mismatch and higher BMI, ideal candidate for fusion. And if you have higher evidence of comorbidity, older age, and you're prioritizing rapid discharge, minimal blood loss, then he will be an ideal MIS candidate. As seen here, the meta-analysis had shown when there is a low PI-LL mismatch and spinopelvic harmony, decompression alone helps in creating, and the p-values were significant in the improvement of VAS-LIX score and VAS-BAC score and ODI. Decompression with fusion was significant and high prompts when patient had a high PI-LL mismatch and sagittal malalignment. So nowadays we are in the era of precision spine surgery where a patient outcome, one size does not fit all. It's very important to look at all the factors and finally keep the patient as the center of your treatment matrix. So when you have a symptomatic grade 1 listhesis, look for imaging and look for PI-LL check. If it is stable, aligned, and midline sparing, decompression alone is fine. If it is unstable and there is PI-LL mismatch or extensive decompression is required, go for MIS fusion or open fusion. That comes to the end of the first talk. Now we are having a brief introduction onto how do we manage management of past fracture, as this goes hand in hand with low-grade spondylolisthesis. The past fracture is an acquired fatigue fracture of the young athletes. It's most commonly seen in athletes because of the constant shear force, constant lordosis, constant weightlifting, swimming, and running, and most commonly seen in fast bowlers. And overall, there is a general increase in the amount of pars fracture. That is because of increase in athletic spike. So what really happens, there's a first stage of spondylolysis where there is a repetitive stress that leads to the fracture in the pars, as seen here. And if left untreated and continues to progress, can result in spondylolisthesis. Why L5 is the most commonly prone for this? It's because of the biomechanics. There is a lateral bony ridge narrows significantly at L5 and it reduces the structural integrity. And there is a pincer effect from the L5 pars integrity gets compressed between L4 inferior articular and S1 superior articular process because of the hyperlordosis. They usually present with mechanical low back pain. They're present with hamstring tightness, radiculopathy if there is progression to spondylolisthesis, and palpable step deformity. In standard lateral radiographs helps in picking up and also helps to assess the percentage of slip. Oblique view shows the Scotty dog pars defect. Plexus extension helps in assessing the instability in this group of patients. As seen here, there is early, progressive, and terminal. So treatable stage is 0 and 2. Pseudoarthrosis is where you have grade 3 terminal stage. These are the latest CT-based and MRI-based classification as propagated by Morita group and Satsumura classification for pars fractures. So how do you manage these patients? Always conservative management comes as the first line of treatment. You allow them to modify their activity, reduce the stress, physiotherapy, and bracing in selected cases. A little word about lipus. This is a low intensity pulsed ultrasound. Daily giving a stimulation of 20 minutes per day helps in regenerating the bony matrix, reduces the inflammation, and helps healing for the fibrosis. And this has been found to be effective in certain group of people. Also note on core strengthening and hamstring and a lumbar brace. What are the predictors for union? Who heals without surgery? When there is absent fracture line, when there's only defect is unilateral, and when there's excellent patient compliance with bracing and absence of contralateral pars fracture, these are the factors that promote healing without surgery. Then what are the indications for surgery? The first foremost indication is a failure of conservative treatment, and those who continue to have neurological deficit and progression of slip and intractable pain affecting their quality of life. What surgical principles that needs to be kept in mind? There are 3 pillars for pars fracture. First one is debridement. As you all know, there is a pseudoarthrosis, so we need to remove the pseudoarthrosis tissue. And bone grafting from the iliac bone or from a cancellous bone in between the pars defect helps in fusion, and direct compression, applying a rigid construct across the defect. The surgical goal is to ensure there is stability with mobility. What are the main controversies here? We have to discuss about, is there a role for direct repair versus fusion? Pars repair, direct fusion helps in young patients, but if there is a degenerative disc disease or collapse, fusion is ideal. Goal is to always have a motion and avoid adjacent segment disease. So the 3 famous techniques that has been described in literature is Buck's technique, which is a direct screw fixation, Scott interlaminar wiring technique, Mosher pedicle hook, and the laminar screws. Pedicle screws with a laminar hook technique is the well-described techniques. The modern techniques is put a pedicle screw and a U-shaped rod across the lamina. This has improved biomechanical stability and better union rates. Let's look to each of this. As mentioned earlier, the first most important is remove of the fibrous tissue and expose the bleeding cancellous bone, which is very essential for union. The second step is to place the autologous bone graft within the pars defect, as this enhances the fusion potential. The next step is direct compression across the defect using fluoroscopy and navigation, and ensure that we have accurate hardware placement. The latest approach is a minimal invasive and also robotic. They have come up in a big way. The TLIF does not preserve the motion, where direct pars repair preserves the motion. And direct parts repair has low adjacent segment stress and has good fusion rates which are comparable. What are the complications that we are looking at? One is non-union, hardware failure, nerve injury, and an infection tend to appear whenever there is any surgical procedure. Outcomes that we look at is the high union rates, preservation of motion, and good functional outcomes. Which is the biomechanically rigid construct? It's the pedicle screw and the rod that is placed across the pedicle screws. Buck technique has a strong compressive force. Scott has less stable biomechanics. As seen here, Buck screw places a lag screw here. So we place a screw from the lamina directed towards the pedicle, and we interpose the graft and fix the screw towards it. A cortical screw is placed. It's highly rigid and it is a low profile and the less tissue dissection. This was introduced by Buck in 1970. Typically, we use a 3.5 to 4.5 cortical lag screw. Whereas Scott technique involves excessive tissue dissection from one transverse process to the other transverse process, and also dissection of the roots and placement of the laminar wires from one transverse process across and tightening it so that it helps in fusion. This is a Mosher repair where you have pedicle screws and then you have the laminar hooks. There you have the hooks that is going this. Whereas this is the pedicle screw, this is a modern technique. You have the pedicle screw on a U-shaped rod hooked across the lamina. This D, the picture D, is supposed to have a high rates of fusion and less complication. Bucks has good fusion and direct compression, but the complications are more high in Scott's repair. As seen here, the complication rates between the Bucks and Scots, it's less in Bucks, whereas high in Scots because of significant muscle stripping and role of a nerve injury. There is a biomechanical superiority, sometimes has faced a failure rates because of the screw getting pulled out and graft resorption. And there's a fatigue breakage of the screw that results in conversion to fusion. Whereas Scott has a very good advantage that there's only 2.7% of conversion to fusion. We have touched this already. So this is the latest meta-analysis that's published in JNS, which has compared the 4 techniques. One is the pedicle screw, which has a very high fusion rate of almost close to 90%. Buck comes next, is comparable. Complication rates are less, it's 12.8%. The overall positive outcome is close to 80%. Whereas Mosher repair has low values as compared to the other techniques. So the final verdict is direct parts repair requires balancing and biomechanical is to long-term dynamic healing. Modern evolution like pedicle screw and interlaminar hook system increasingly attempt to marry the rigid cortical perches of Bucks and dynamic tension band properties of Scots. So would prefer the latest technique of pedicle screw with a U-shaped rod. Thank you.
Hello. Jonathan, can you hear me?
Yes or no?
Excellent presentation. Very articulate in your presentation. You have covered the topic nicely. Thank you so much. We
Thanks,
invite our next speaker, Dr. Nilay Biswas, to kindly talk on high-grade spondylolisthesis and including the high dysplastic type. And there is always a dilemma whether you have to end the construct at S1 or whether you have to extend the fusion and make it an ideal lumbar fixation, especially in the high dysplastic category. So I invite Dr. Nilay Biswas to kindly start his session.
Am I audible?
Yes.
And my screen, is it?
Yes.
Yes. Okay. So good evening. Particular thanks to Dr. Sanu and all the moderators and coordinators for giving me this opportunity to talk on hybrid spondylolisthesis. Now, as already we have said with Dr. Akshay enumerating the various classifications. So basically spondylolisthesis is first classified by this Meyer-Dean classification. And here, depending on the percentage of slip of the vertebra above over the vertebra below, we divide the slip into low grade and high grade. And grades which are slips over 50%, they are considered as high grade. That is slips which are more than 50%. So it includes type 3, which is 50 to 75%, type 4, which is 75 to 100, and type 5, which is more than 100%. And high-grade listhesis is being seen in about 11% of all spondylolisthesis cases. So it's not that frequent. Now, this X-ray, it shows the three types which encompasses the high-grade listhesis. In A, we can see that the slip is about more than 50%, is 50 to 75. In the middle picture, we can see that it's between 75 to 100. And in C, we see that it is more than 100%. Now, I will briefly touch upon a little bit of the classification as it has some bearing on the treatment also. Now, this first classification by Wilson, Newman, McNabb, already discussed by Dr. Ashray, and where it has been divided into dysplastic and ischemic type. And this was based mostly on the etiological aspect of the spondylolisthesis. So, this classification does not provide any guidelines for the treatment. Next is the Marchetti and the Bartolozzi classification. And here, this classification is more suited for management because it is dividing the development type into two types, what is high dysplastic and low dysplastic. And these high dysplastic ones are the ones that require surgical correction and require special types of surgery like we are about to see later. Now, how to differentiate between whether a listhesis is a low dysplastic one or a high dysplastic one. Now, characteristic of a low dysplastic one is a relatively normal lumbosacral profile. This is very important. There is no junctional kyphosis, a normal appearing rectangular L5 vertebra, a normal S1 superior end plate, and there is no pelvic retroversion or a compensatory hyperlordosis. And these are associated with very low risk of slip progression. Whereas in the high dysplastic type, they are present with a lumbosacral kyphosis. They have a trapezoidal L5 vertebral body. The superior surface or the end plate of S1 is dome-shaped, and there is pelvic retroversion and hyperlordosis. And these are associated with a high risk of slip progression. And these are important because from the management point of view also. So if you see at the images here, these high-grade listhesis, high dysplastic types, these are often associated with there is dysplasia of the facet joints, and there may be some bifid arches. There is trapezoid shape of the L5 body. There is dome-shaped superior surface of the S1, and so these are associated with high risk of slip progression. Now, the next classification, and this is the classification which has the most significant one in terms of choosing the management. And this depends on whether the pelvis is a balanced one or a retroverted one, and if the retroverted one is associated with a balanced spine or unbalanced spine. I'm not going into the details of the classification as it has already been discussed. Now, the key difference between a low and a high dysplastic spondylolisthesis is the pelvic retroversion, which is present only in high dysplastic subtype. And that leads to a high chances of this slip progression. So, if you look at this high-grade spondylolisthesis, and one is a balanced pelvis and one is a retroverted pelvis. Now, these parameters which we have already discussed. So, we see in a balanced pelvis, there is no retroversion of the pelvis. So there is a high sacral slope and there is a low peak. You can easily make out with the image that here the sacral slope is larger and the PT is less. But just imagine that the pelvis is getting retroverted. That is, the sacrum is becoming more vertical. So obviously you can make out that the sacral slope will decrease, whereas the pelvic tilt will increase. So that is what is a retroverted pelvis. Now, coming to the clinical evaluation of these patients. So normally they present with a non-specific low back pain. They rarely present with radiculopathy, and there is often a history of activities requiring hyperextension or like gymnasts and athletes, and they are more prone to develop this sort of listhesis. And on clinical examination, sometimes you can feel a definite visible, or sometimes you may palpate it a step off because of the junctional kyphosis. There may be tenderness in the lumbodorsal fascia and over the SI joints, which are more in favor of high grade sleep. And very important is a gait assessment. This is because of this spinopelvic misalignment, because of the sacrum getting more vertical, the pelvis become retroverted. These patients are having a tight hamstring. And so you will find that they are generally walk with a wide base stance, and there is a flexion at the hip and the knee joints. So by inspection also you can make out that this is a high grade sleep and a high dysplastic one. Coming to the diagnostic imaging, the first and foremost what we require is a whole spine standing X-ray, that is a weight bearing one. This is very important because we need to see the spinopelvic parameters as well as the sagittal balance. And also we need a dynamic film, that is flexion extension view of the thoracic and lumbar spine. Now, the parameters has also been discussed, and these help us in determining the value, will help us in determining the choice of treatment and the degree of reduction that is needed. Coming to sleep angle, which is the angle formed by the inferior surface of the L5 and the posterior perpendicular from the posterior surface of S1. This angle is important in terms in high grade listhesis because it will enable us to know the degree, the chances of the sleep progression, and who will require surgery to correct the sleep progression. Other imaging modalities we do were the CT scans and the MRI scans. Here also mostly we see important features like about the thickness of the L5 pedicle. This is very important in case of high-grade listhesis. Sometimes the pedicles are very narrow and it will be difficult to put in a pedicular screw. So pre-operatively you should have an idea about the size of the pedicles. And MRI scans to know whether there is any neural structures getting compressed. Now, this study by Lamartina et al., and it's a very elaborate paper where they very nicely describe what are the approach to a treatment of a high-grade listhesis. So they basically discuss three things. One is the severity index, one is the unstable zone, and the reduction which is required. So if we see these things, what is the severity index? The severity index, it helps to know whether what are the chances of this sleep getting going to progress in future. So those with a high severity index, they will require surgical correction. Next is the unstable zone. The unstable zone is that many a times we are face a dilemma in high grade that whether we need to include the L4 vertebra into our fusion zone, into our construct. And this can be, rather than choosing arbitrarily, this paper, it very nicely describes how to choose whether we have to include L4 into our fusion zone. And also it outlines in detail the surgical approach which is required for reduction and stabilization. So coming to each one of them, if you see the sleep index, which can be calculated by this on a lateral standing radiograph of the spinopelvic region, and it should include the femoral head, that is the hip. And in a normal subject, see, we draw a line from the center of the S2 vertebral body and a horizontal line. A vertical line is drawn from the center of the femoral head, and another vertical line is drawn on it from the midpoint of the inferior surface of the L5 body. So distance between the two vertical lines is D1, and the distance between the midpoint of S2 and this vertical line from the femoral head is D2. Now, this is in a normal subject where the severity index is described by the formula of D1 by D2 into 100, and it's around 15%, 14-15%. Now see what happens in a low dysplastic. If you remember the image earlier, there is not much retroversion of the pelvis. And here, and with a normal size L5 body, here there is a little increase in the D1, and the severity index comes at 20%, close to 20%. But what happens in a high dysplastic type is that because of this further sleep and changes in the bone, the severity index comes to be 63%. Now, this is clinically very significant because if you, by measuring the severity index, you can decide that whom to go for intervention. And if you see at this example of an X-ray of a 12-year-old girl, it showed a slippage of 28% with a severity index of 31%. So the severity index was high, even though the slippage was low. Now, on 1 year later, the slippage progressed to 86%, whereas the severity index also increased. But if we follow the severity index, we would have got an idea that this slip is going to progress, and that this patient will require surgical correction. Next is the unstable zone. Now, this is again a few lines. One is the horizontal reference line from the center of the S2, two vertical reference lines, and one is from the center of the femoral head, and the other is from the midpoint of the inferior border of L5. And where this two vertical line cuts this horizontal reference line, this area, this of a square, is drawn, and the vertebra which is included in this square area is actually the vertebra we should include in our fusion. So this also gives us a very good idea about when to extend the fusion to upper level, that is L4. So this is just example where we see that in the MRI there is a slip. We can see when we should decide. We should see the severity index, and then depending on that and unstable zone delineation, we can decide on the nature of the construct and the need for surgery. Now, the most important thing is that is in case of low dysplastic type, there is not much sagittal imbalance. This is because there is so in case of low dysplastic type, reduction is not needed always. So this concept is also very important. And whereas in the case of high dysplastic type, because of the changes in the spinopelvic measurements, and there is compensatory. If you see in this patient, there is straightening of the back, there is kyphosis, there is hyperlordosis above in the lumbar region, there is tight hamstrings leading to flexion of the knees and the hip. In these cases, we need reduction and fusion in order to improve the sagittal balance. Now, non-operative treatment in high-grade listhesis also there is a role of non-operative treatment with physical exercises and muscle strengthening exercises. And these are generally done when there is no, if the patient is asymptomatic, if it has been incidentally detected. Now, all the evidence in literature, they support that intervention for only symptomatic high-grade listhesis. And in case of asymptomatic ones, we can consider conservative management, provided the other parameters like the severity index is within normal. Now, what are the indications of surgery in case of high-grade listhesis? One is the persistent symptoms. Number two is the failure of conservative management. And radiographic parameters, which is suggestive of sleep progression and significant biomechanical stress. That is the severity index and the other types like the whether it's a high dysplastic one, and leading to a global sagittal imbalance. So all these things will require a surgical treatment. What are the options for surgery? The options are number one, in situ fusion techniques. We can use posterolateral fusion. We can use anterior or circumferential approaches also. And second is fusion and reduction. of the deformity. And this can be complete reduction or it can be partial reduction also. And also very rarely in cases of spondyloptosis, there may be an option of vertebrectomy, though it is less commonly done because of the morbidity. Now, if you see at the studies comparing in situ fixation of high-grade listhesis, and these studies have shown that though the in situ fusion, it does not improve the cosmesis. Okay, and all the cases which are done, which I've done, I've seen that if you look at the post of X-ray, it looks horrible. There is the the defect is still persisting and there are screws going everywhere. But if you see at the patient satisfaction and the quality of life, that is the pain relief and their ability to move around, the ambulation, these are markedly improved. Even and this improvement persists long term also. So the long term results of in situ fusion are good. And these are one example of a case where it has been done in situ fusion, a fusion from L3 to S2, including the ILX group. And even all the papers, there are a lot of papers. We have studied the long-term follow-up of these patients for high grade, that is grade 3, grade 4 listhesis. And they have found that the quality of life as well as the pain relief is very good and it persists even in the long term. Next, there are various types of in situ fusion techniques. And one such option which was described by Bolman et al. And it was a condition where the fusion of the L5, which was lying in front of the S1, through a transvertebral, transsacral fusion. So what they are doing a wide decompression from L5 to S2. They're doing wide L5 foraminotomies so that the nerves get decompressed and they are not damaged during reduction. And then a bony tunnel is created from the posterior border of S1 to the anterior body of L5 through the L5-S1 disc. And in their studies, they put in a fibular strut graft through the tunnel to impact it, thereby giving a very good anterior fusion of the vertebrae. And they reinforced it by putting in posterolateral bone grafts from L4 to the sacral. So it's a circumferential fusion. Now, this technique has been modified later, where instead of the fibular strut graft, you can put in a mesh cage through the root which is created between the S1 and the L5. We can put in a mesh cage packed with bone graft, and this will give us solid fusion. Similar in principle is the delta fixation, or what we call as a transsacral, that is through the L5-S1 disc, as this image is showing that in this case, where one screw is passed from the sacral, from the sacrum through the L5-S1 disc and into the body of the L5 vertebra, and then we put in a transpedicular screw in the L5 and fix it. And the starting point, entry point of the sacral screw is the point of entry of the sacral pedicle screw. And these screws are being directed in a cranial direction under fluoroscopy guidance and medial about 15 to 20 degrees. This group from this paper by Tamburelli et al. And they modified this technique of this transdiscal L5-S1 screws by choosing an entry point which was a little medial and below the S1 pedicle point. And the rationale being doing this is that they are putting screws in the L5 pedicle, S1 pedicle as well, and separately they are putting two screws on both sides from the new entry point, L5-S1 disc screw from S1 to L5. So it is providing a more solid construct and with more chances of fusion for a in situ fixation technique. And now, when do we require reduction then? Now, reduction is required of the defect when it is having a high slip angle. Slip angles of more than 45 degrees or severe sagittal imbalance. There is increased risk of pseudoarthrosis with in situ fusion. If we get that there is a presence of radiculopathy that will require a decompression. In high-grade dysplastic types, as already mentioned, if there is a hypermobility of the L5-S1 segment, and if there is a dysmorphic lumbosacral junction with small transverse process, there is dysplasia of the sacral facets, trapezoidal L5 vertebral body, or rounding of the sacrum. These are if these are present, it is a high chances of the sleep progression and pseudoarthrosis, even with in situ fusion. And there comes the role of reduction and fusion. And when we are doing a reduction and fusion, it is imperative that we put in an interbody cage packed with bone in order to augment this fusion and to fuse it under compression. Now, this is an example of where this listhesis, this slip was corrected from the posterior approach only with the help of pedicular screws and a transforaminal interbody fusion. And look at this correction of the degree of reduction from pre-op to the post-op. Now coming to the advantages and disadvantages of both the procedures. Now in situ fusion, as you can understand, is a lower risk of neurological deficit because there is less chance of traction on the nerve roots L4 or L5. It takes shorter operative times and there is less blood loss. But the disadvantage is that the deformity is not corrected, so there will be a possibility of sleep progression. There is a higher risk of pseudoarthrosis and the cosmetic deformity is not corrected. On the other hand, reduction, the advantages is that improved biomechanics. The spinopelvic parameters are corrected, fusion rates are higher because we are getting a more area for fusion because of the reduction and the cosmetic correction is there. But the disadvantage is that there is a significant risk of neurological deficit, and some studies, the L5 nerve root affection is around almost 20%. Though in many of the studies it was a transient one, but still the permanent deficits of around 5% is reported. And there are like from this study, and there are a lot of studies which have documented a comparable clinical outcome between in situ and reduction at even long-term follow-up. So this is very important that if we subject a patient to reduction at a cost of a more lengthy procedure with a more morbidity and chances of nerve injury, whether we're doing the right thing, because there are lots of reports in literature which has and there are long-term follow-ups which have shown that there are comparable results when the two are compared. So till now in literature, there is no clear-cut evidence to choose one method over the other. Now, some studies have shown that during the process of complete reduction, they noticed that the maximum deficits occurred when the reduction crossed more than 50%. So from this came the concept of a partial reduction and fusion. This is important because if we this will correct the spinopelvic balance to some extent and provide good relief, and at the same time it avoids the neural chances of neural deficits. So this partial reduction is one other option where there is partial reduction of the deformity leading to less stretch on the nerve roots. Now coming to the reduction techniques for high-grade listhesis, and in cases of very dysplastic types, sometimes we have to include the L4 to put in the lift the L5 for proper reduction, and sometimes you have to even the L5 pedicles are so deeply buried that you have to take a lot of help of fluoroscopy, and at the same time sometimes you have to distract between L4 and S1 screws in order to just locate the L5 screws, L5 screw entry point, the pedicles. So, and then we have to go for a wide laminectomy to decompress the L5 nerve roots, because during the reduction, otherwise there will be stretching on the roots. And we do a very radical L5S1 discectomy, leaving behind the annulus, and we put in a sequential cages of lordotic cages and putting the cages as much anteriorly as possible and gradually increasing the cage size to reduce the deformity. And sometimes because of the sacral dome in the high dysplastic types, the L5 body may not come, it's difficult to reduce the L5 body behind, and in those cases sometimes you require a resection of the sacral dome also. This another procedure which I told as the vertebrectomy. This is done in case of spondyloptosis, though this is not very commonly done in practice, and it was described by Dr. Gaines. And here, by a combined approach, both anterior posterior, they're going for complete resection of the L5 spondyloptotic body, and then they are again going from the back, removing the posterior elements, and they are fusing the L4 on the S1, and then fusion with posterolateral and instrumentation. Now, in terms of high dysplastic high-grade listhesis, you can very well make out that merely fixing the L5 and the S1 will not suffice. As we have to go above to include the L4, similarly, we sometimes have to include the iliac bone into our construct to provide a more rigid construct. So there are various techniques of sacropelvic fixation described in the literature. And before going into the technique, we have to first note that why this iliolumbar fixation or sacropelvic fixation is giving a very strong purchase or a better biomechanical environment. And this depends, if you know that this study from McCord et al., and they showed that in the case of movements in the spinopelvic junction, the pivot is located at the posterior part of the L5S1 disc between the L5S1 interspace. And they divided this paper by O'Brien, where they have divided the sacrum into 3 zones depending on their biomechanical stability. So zone 1, it includes only the S1 vertebra. Zone 2 includes from S2 to the coccyx, and zone 3, it includes the ilium, that is on the anterior and lateral to the sacrum. And the biomechanical purchase of the constructs is highest in the zone 3. This is because it is going into a place which is much anterior to the pivot. So the more anterior and more lateral to the pivot you will go, the more better secured will be your instrumentation. So these are just examples where from L4, L5, S1 and sacropelvic fixation with the iliac screw has been done. One option of a sacropelvic fixation is the S2 pedicle screw. But this is not very advisable because number one, the zone 2 is not a very strong, does not have a very strong biomechanical advantage. And also the S2 pedicle screw lengths are less and the distance from the pivot is not much. And also the amount of bone which is available for purchase is low. So the S2 pedicle, we find that is not a very good biomechanically stable construct. Now coming to iliac screws. So these iliac screws are put with 3, these are described very nicely in this AO surgical reference from where I have taken this picture. And they have discussed 3 entry points. One is a traditional entry point, one is an anatomic entry point, and one is a sacral entry point. The traditional entry point is the posterior superior iliac spine just below the posterior superior iliac spine. A groove is created in the posterior superior iliac spine because this the muscle which is available here for covering the screw head is less, and this screws has a tendency for spin breakdown and exposure of the screws because here the subcutaneous fat is less and the muscle cover is less. So to avoid this, what is done is a weight shift part of the posterior superior spine is cut in order to put the head of the screw into the shell so that it doesn't come in contact with the subcutaneous skin. And from this entry point, it is directed, the screw trajectory, it is directed towards the anterior inferior and iliac spine. The anterior inferior iliac spine, that is where it is directed, and it should cross the about 2 centimeters above the sciatic nerve to avoid injury to the sciatic nerve and the greater and the vessels there. So this is how our entry point is first created, and then with the help of a drill or a probe, this trajectory is then created. Now the second entry point is that it is done a little medial to what is the anatomical entry point. The idea being to make the screw less hide it under the bone so that there is less chance of skin breakage. And the third way of putting in the screw is more medial, starting from a more medial towards the sacrum and then directed towards the anterior inferior iliac spine. Now, to put the screws, we require two X-ray views. One is a true lateral view, where true lateral means the two sciatic notches they should superimpose, and the screw is directed in this dense bone, which is about 2 centimeter above the notch, so that it does not damage the sciatic nerve. And we take a obturator inlet view, and to where we get this in a AP, and we get this teardrop appearance of this ileum, and the screw, entire screw should be available, should be seen within that teardrop to avoid any breach of the iliac surfaces. Now, another technique of this iliolumbar fixation or the spinopelvic fixation is the S2 iliac technique. And this was described by Sponseller et al. And here what is done is that the S2 alar iliac. So it crosses the sacroiliac joint, the screw, and it crosses the joint and then goes into the ilium. So the advantages of the S2 alar iliac screw over the iliac screw is that, number one, the screw entry point is in alignment with the S1 pedicle entry point. So you don't require an extra hardware to connect the rods or extra connector to connect the rods. And also it is in alignment with the construct Kefauver, that is the L4 or the L5 screw. So putting in the rod is much easier when we use a S2 alar iliac screw. And this is the entry point is between the S1 and S2 neural foramina. And from there, it is directed under fluoroscopy guidance laterally and caudally. Caudally, again, it is directed towards the anterior-inferior iliac spine. And in the lateral, it has to cross about at least 2 centimeters above the sciatic notch and in towards the anterior-inferior iliac spine. Now, and there are studies which have shown that the use of this S2 or iliac screw is associated with less this implant or hardware-related complications than compared to the iliac screws in adult lumbosacropelvic fixation. So, thank you.
Thank you, Dr. Nilay Biswas, for your excellent presentation. Now I would like to invite Dr. Umesh Srikanta to present his talk on minimally invasive approach.
ಇಲ್ಲಿ ಮುಂದೆ ನಿಲ್ಲಿಸ್ಬಿಡಿ ಅದು ತೋಲ ತಗ್ಸು.
Hi, sir.
Yeah, Dr. Nilay, can you stop sharing your screen so that I can start?
Yes.
Yeah.
Yeah, good evening, everybody. Thank you, NSI, for giving me this opportunity to present our experience on, in minimal invasive approaches for spondylolisthesis. And so I'll try to keep it to time as much as possible. So minimal invasive approaches for spondylolisthesis is not a new thing. I think, if we have heard the lectures that have been given till now, the main two methods of reduction or anatomical lordosis restoration in listhesis is based on these two techniques. One is either you have to reduce it using interbody distraction techniques, or you have to use it using screw-based manipulation techniques. And now there are advantages and disadvantages of each. Interbody distraction usually is better because you are doing the work intradiscally and there is less manipulation of the screw. You can use your instruments inside the disc in order to reduce or change the lumbosacral kyphotic angle or the slip angle as it's been described earlier as well. So the screw-based manipulation is basically based on putting the screw, tightening the inni and converting the lower screw into the monoaxial screw and pushing the rod into the upper screw, which ultimately pulls the vertebral body, the slipped vertebral body upwards. And this is something that we all follow in our things. Now, when we talk about these techniques in minimal invasive approaches, as you can see, the minimal invasive systems do have an inbuilt mechanism for achieving this kind of a reduction. We don't need any additional kind of a reducer that has to be attached on the tulips, any additional type of a reduction sleeve screws. That is not required because the MIS screws. But obviously, the basic principles of a good screw purchase is important, especially even in MIS, especially in the presence of osteoporosis. And these things can be easily achieved, much more easily achieved in MIS techniques because of the more lateral to medial angulation that we can get while putting MIS screws rather than an open technique where you will have to do a significant amount of muscle dissection to get a lateral to medial angulation, especially as we go lower down into S1 as well as into the lower spine. And so in simple things, in simple spondylolisthesis, usually the correction or the lordosis restoration is achieved just by positioning or by interbody distraction itself. By just putting in a cage, you can achieve a good amount of reduction, good amount of distraction, as well as lordosis restoration in these kind of cases. And that is something that is easily achievable. Cases where uh, the positioning or an interbody distance itself is not achieving achieving the reduction or lordosis. Usually what we can also do is put in screws from the other side, the percutaneous screws, and use those screws to manipulate and or to achieve the reduction of these vertebral bodies, as you can see in these images, as we can see there. So the similar techniques that we use in an open surgery can also be used in a minimally invasive approach in order to achieve this kind of a reduction as well as lordosis restoration also. But we have to understand that these screw-based manipulation techniques is not at all ideal, especially whenever there is an osteoporosis. And the best way to do this intradiscal or to achieve reduction of listhesis is by doing as much of intradiscal work as possible and as little of screw-based manipulation as possible. Now, bicortical screws is one way to improve the screw purchase in osteoporosis, but as we know, they are quite dangerous in minimally invasive approaches because of the guide wire related application. Other option where we can put in cement into these percutaneous screws and actually improve the purchase of these screws to achieve the reduction of tough as well as slightly stiff listhesis like these cases, like this in these cases. So another technique that can be used in minimally invasive approaches is you can do a bilateral release. As you can see there, you put in your tube on the first side, you do your facetectomy and discectomy, put in the screws on the first side after removing the tube, and then put the tube from the contralateral side, and then do a contralateral facetectomy and discectomy. Now, basically, you have released both sides facets and you have done bilateral aneurysm and discectomy. The listhesis becomes relatively mobile, and it is something that can be used even in minimal invasive techniques as well in order to achieve in tough listhesis. Augmented fixation is something that can be preferentially or easily done even in minimal access techniques. And this is what I was mentioning. Bilateral simultaneous manipulations, bilateral simultaneous as well as reductions can be done using intradiscal, predominantly intradiscal work, and in these cases, and even tough listhesis like this grade 2, grade 3 can be reduced using minimal invasive techniques. The cages help us to go in small and distract the vertebral body in order to achieve this kind of a reduction that is required. And even in tough cases like this, body restoration, even with a posterior approach in these cases. So as you can see, there is a significant difference. But how much have we actually achieved? How much have we actually made a difference with MIS TLIF? Now, if you see all the other complications of minimal invasive of TLIF, transforaminal lumbar interbody fusion, are still existing with MIS TLIF, except for the paraspinal muscle. You still have a risk of epidural fibrosis. You still have a risk of dural or a nerve root injury, operative radicalized and that is where these newer approaches of lateral approaches or retroperitoneal minimally invasive approaches have come in, which can easily, or you can use these approaches to reduce the spondylolisthesis. Now, the mechanism, these approaches are basically, lateral retroperitoneal approaches where we enter the disc through the virgin area between the anterior border of the psoas and the lateral border of the blood vessels, either the aorta or the common iliac vessels. And this area it doesn't have any significant structures except for the sympathetic chain. So and by entering the disc into these areas, this approach preserves all the ligaments of the spine. You're not removing any bone, you're not removing any ligament facets, the ligamentum flavum, the posterior, anterior, longitudinal ligaments, everything of these, all of these are preserved, and that is how it acts. And as you can see, the higher the amount of distraction that we can achieve, which is slightly more difficult with a posterior approach, the more amount of the distraction that we can achieve, the better restoration of lordosis as well as restoration of the disc height and foraminal height. Approaches, and that is something that can be done using using a single stage lateral approach as well. The earlier there were disadvantages of that we do a retroperitoneal approach with a patient in the right lateral position, and then again you have to flip the patient posterior to put in a percutaneous pedicle screw. But now with more advances with intraoperative neuronavigation with robotic guidances, single stage lateral position approaches where you can put in the screws in the lateral position where the patient is in the right lateral decubitus position, and all this can be done. So simple cases like these, with just interbody distraction and no bone or ligament removal, we can achieve actually a good amount of canal remodeling. As you can see there, a good amount of opening up of the canal, even without removing any of the ligament or a posterior annulus. Even collapsed disc spaces with around grade 1, grade 2 listhesis can be easily reduced, a good amount of reduction as well as, and this is not a screw-based manipulation reduction. This is only through interbody distraction. It is not at all a screw-based. The screws will be put later on after the cage has been placed. And even in significant stenosis, good amount of opening up of good amount of decompression of the lateral races as well as the foramen can be adequately achieved by just putting in a large cage into the disc and increasing the disc height distraction. Now, even in these cases, usually what we do is whenever there is a collapsed disc space, we can actually go in and we can do these supine extension view x-rays, which actually shows the amount of opening up of the anterior annulus, opening up of the anterior part of the vertebra, and that is if that is a good sign and the intradiscal vacuum appears at that particular point in time, as you can see, the difference between a standing extension and a supine extension is quite significant, and these cases are also suitable for a minimally invasive lateral retroperitoneal approaches. Now, when it comes to L5S1, obviously you have either an ALIF or a lateral approach OLIF 5-1, which we prefer nowadays because it can be done in the lateral position. If required, you can go up all the way to L2 or L1 if in the same position without changing the position from a supine to a lateral position. And also the lateral approaches also help us to put in posterior percutaneous pedicle screws at the same time. So that is something that can be done. So with minimally invasive approaches, you can actually use different retractor types in order to go in vessels that we see, and we identify the gently take that, do a significant, do a wide annulotomy. The annulotomy and end plate preparation is done, you can actually use a cage. This is actually an indigenously designed cage that we have developed for a approach to an L5S1 disc space. And look at the ease that once the L5S1 has to go to L4-5, we just have to cross the iliac vessels and go across into the upper disc. That is the L4-5 disc where you can do a regular OLIF that we are doing. So that is the sympathetic chain, as you can see there. That is the sympathetic chain. Actually, a few fibers can to something that can be achieved a single lateral position where you're working from front as well as your guide wires are already there from the back. And this is something that these outcomes can be achieved very easily in these cases. But what if the vascular anatomy is not suitable for OLIF? Now, what if it is not suitable? Do we really have to go back to doing TLIF, doing the facetectomies and doing the, handling the nerve roots in those cases? And as you can see, there can be a significant. And in these cases, the new kid on the block, a more minimally invasive approach is the transcambin lumbar interbody fusion, or something that we are calling it as KLIF, or some people refer to it as OLLIF. So in these cases, the entry is through the Cambin's triangle, as the name itself says, which is basically the gap between the exiting as well as the lateral border of the dura on the upper border of the pedicle. And you can even chart out the anatomy of the exiting safe entry point into the disc. But however, in order to be safe, it is always better to go in to the to the superior articular, to the base of the superior articular process, and then to the upper end plate, and then go into the disc space, and that is the way. So this this is one of the navigation guided K-leaf approaches, as you can see there. So we can actually enter the disk space, and once you are inside, you are doing it with CMG monitoring so that you are not causing any kind of an irritation exiting nerve root. And once that is done, it is quite easily, you can achieve a good result. You have endoscopic curettes, you have the disc preparation materials that can go through. And nowadays, even whenever there is the Cabin's triangle or the Cabin's window is small, you can actually put in a tube, an 18 millimeter or a 16 millimeter long tube on the side in order to prepare your end plates, as well as put in your graft material through the same tube. And this also is something that can be done. And the cage essentially goes on a guide wire. So as you can see that is the amount of distraction, that is the amount of reduction that we can achieve using this. So there are several minimally invasive options for spondylolisthesis, MIS, T-leaf, 4-leaf, anterior approaches, the transcambin, as well as an endoscopic lumbar interbody fusion. There are some difficult scenarios that we can come across. You have high-grade listhesis, you have a collapsed disc space, you have severe facetal hypertrophy or a severe canal stenosis. And, these things can actually be, taken care by considering these factors. I'll be quite quick for this because of lack of time. So these are the basic principles that we need to consider in listhesis reduction, whether it is an open or an MIS technique. And in MIS, it is always possible to achieve a good anchorage through the newer techniques of 3D worm navigation, or even a robotic system where the anchorage or a good screw purchase can be achieved. An adequate decompression, even in severe bony canal stenosis, can be achieved either by putting in the tube from both the sides and doing a good decompression, or putting in tube from one side and doing an overall So you can actually achieve bilateral fastectomies, as I was showing in examples also, a bilateral preannular release, bilateral discectomy, as well as a lateral annular release, especially in tough cases. It can all be done through minimal invasive approaches as well. And these are some of the examples which we have already shown. Now, reduction, as I said, it is already inbuilt in minimal invasive techniques. And as long as our screw purchase is good, then we can actually reduce the listhesis in a very good way without any difficulty. Now, again, the topic that has been discussed so much today is to maintain spinopelvic harmony despite having these, despite doing all these cases. So we have already listened to these parameters. Lordosis distribution index has not been stretched too much, but that is something that is very, very important for a single level or 2-level lumbar fusions that we are doing. It is very important. And it's also important to recognize the variations in the pelvic incidence and the spinopelvic parameters between different patients. And this is something that I added just now, because there are patients who have low PI, who have a low compensatory potential in pathological state. And there are patients who have high PI, who have inbuilt high PI, and who have more compensatory potential in pathological state. And these different types of spines also have to be identified when we are correcting, especially the L4-5, L5S1, because as you can see, the different type of pathologies in these different different type of spinal curvature in the normative population can vary significantly between type 1 as well as type 4. As you can see that these are the Rosoli types. I'll not be able to go into the details for this. Now, basically, these are the ideals that we want to consider, whether it is MIS or an open. We need to have a global alignment, that is your sagittal vertical axis should be less than 5. Your PT should be less than 20, which is the second most important thing. And the PILL mismatch should be less than 10. And of course, the lordosis distribution in index, which is coming up in a big way due to these gap scores, that is should be between around 50 to 80 degrees. So I showed this example in the beginning. Now, what do you feel about this? So this is something that has completely lost its spinopelvic harmony, even though we have achieved a good reduction in this particular case. Now, there are several different techniques. You can do a bilateral facetectomy. Using MIS techniques, you can put your cage anterior and do a compression posteriorly, or you can use expandable cages in order to achieve good lordosis or good restore or maintain lordosis in these particular cases. So these are some of the examples. Again, as you can see there, it is important to measure these parameters even in our single level or two level cases. It is important to consider these factors and see if they are abnormal to correct it. And of course, anterior approaches have a good amount of superior lordosis preservation. You heard the SDSG classification. SDSG type 3 are the most notorious for, because they have high PI. Most of the times we'll do a posterior approach for this, and then the amount of, the lordosis that we'll be able to restore from back is significantly restricted. And these people are the ones that are that are more prone to developing adjacent segment disease. You have different classification systems. This is something that we can consider for degenerative cases. SSD classification is actually only for ischemic or dysplastic diseases. It cannot be applied for degenerative. Now, this is a classification that is something that can be applied, which considers the spinopelvic parameters and recommends what is the type of surgery that has to be planned whenever these abnormalities are found. And obviously, SDSD type of classification as there. You have to reduce the listhesis in type 5 and type 6. That is something that is very important, whereas reduction is not essential in any of the 1 to 4 types of SDSG classification. And these are the types in these two. That is, type 5 is again possible to do it minimally invasive. Type 6 is something that is, you will have to consider. Either you will have to opt for a hybrid approach, MIS versus open, or sometimes it will require a completely open surgery. So to summarize, MIS is a very good option for spondylolisthesis, and even in difficult cases, all these steps that are required to achieve a good reduction and restore the lordosis can be achieved using minimally invasive techniques. There is a learning curve, obviously, that is something that we have to take care. And basically, this is again the same summary that I want to repeat. Thank you so much for your kind hearing. Thank you.
Thank you, Dr. Umesh Sukanda, for excellent talk and for sparing your time, although you're pressed for time, you're about to travel, I know. Can I now call upon Dr. Sumit Sinha to give his comments?
Well, thank you, Dr. Matthews, for this wonderful knowledge-enhancing, exciting webinar. And listhesis is, I think, it's a bread and butter of a spine surgeon, and it's very apt. Of all the 4 lectures, I mean, it's all of them so wonderful to hear them all. So, I mean, a couple of things, I mean, to be taken care of in spondylolisthesis, whether it is low grade or high grade, I mean, it tests the skill of a spine surgeon, basically, and especially I'm talking about the high grade spondylolisthesis. The onus is on achieving a good functional outcome, good neurology after the surgery. And because most of these patients, they are neurologically intact before the surgery. So it becomes imperative for us for the spine surgeon to maintain and preserve the neurology. So if we talk about the high-grade spondy, in order to prevent the neurology, various authors have stressed upon very many points in order how to save this neurology. So one of the important things is to of course know surgery to be done without the neuromonitoring, and if you have the facilities for neuromonitoring, always go ahead with that, and do not attempt to reduce it without monitoring the neurology. So in the high-grade listhesis, there have been various options to maintain this neurology. For example, use a cantilever beam fixation technique, and slowly you have to be very patient in reducing. Now, this is another type of a deformity, actually. So it is a deformity correction surgery. I'm talking about the high-grade listhesis, especially. So when you are reducing this deformity, one has to be very patient and slowly give pauses in between the correction when you are doing that. And of course, simultaneously monitoring the neurology during the surgery, as I said already. And before we go on to reduce this, one of the most important points in this high-grade listhesis to reduce it is wide decompression of the facets of the foramen, which has been amply stressed upon in both of these talks on all the three talks of the management of spondy. So we have to do wide laminectomies, of course. We have to do facetectomies, and not only these facetectomies, the foramen have to be laid bare open on both the sides before we go on to attempt any correction in these spondy. So for example, because it has been noticed and amply published that the maximum strain on the nerve root, the L5NS for nerve root, is at the end of the correction procedure. 75% of the strain is at the end of the correction procedure. So it's not like, it is not a linear strain, basically. When we start reducing it, when we start reducing the deformity, the maximum strain is at the end. So we have to be most patient at the end of the correction procedure maneuver. That's what we are doing. So when we take care of these small points, the chances of getting a neurology after the surgery and getting surprises, they are minimized. And of course, ample consideration should be given to in situ fusion, especially in high-grade listhesis. Do not compromise the neurology in want of achieving a perfect reduction. For example, if you talk about my practice, I do not give credence to perfect ideal alignment. I know that what I'm talking about. I know the pelvic parameters that people have been talking about over the last years. But in my opinion, the most thing which matters is the patient neurology. Remember, a spondy patient comes walking to a clinic, it should go walking down to his or her home. So this is the most important thing, and a spine surgeon has to do everything at his hand in order to prevent this neurology. So there are problems with the in situ fixation, in situ fusion, like pseudoarthrosis and all, which one has to keep in mind. And its spondy correction surgery is all about the balance between obtaining a perfect alignment and maintaining the neurology at the end of the day. So these are my 2 cents about this, and hearty congratulations all the 4 speakers. Wonderful lectures, and really enjoyed them a lot.
Thank you, Dr. Sumit. Can I, is Dr. Sajesh Menon available?
Yes.
Yeah. Dr. Sajesh, can you give your critical comments and your observations?
Okay, thank you. Thank you very much, Dr. Matthew and Dr. Sanu. The same thing, I want to affirm that safety of the surgery is more important, not the radiological reduction or radiological cosmosis. What we have to do is to L5 root deficit is a very common if you try for a complete reduction in high spondylolisthesis, and one should be very careful. You need some reduction, yes, of course, but never ever try for a 100% reduction unless it is a small grade 1 or grade 2 listhesis. But in a high grade listhesis, you can achieve spinal balance without without making 100% reduction as well. Then second point I want to stress here is in young patients below 10 years and old, whether to go for with the L5S1 listhesis dysplastic type, whether to go for an L1 screw, L4 screw along with L5 and S1 screws. Sometimes we have to go for Lamartinas are all discussed, I know, but sometimes even if this that square is not landing at the L4, sometimes we have to go for a L4 screws as well to get a proper alignment and proper reduction. Third point is spondyloptosis. Nobody has discussed much about it, because once the vertebra is anterior L5 is anterior to S1 and all. Some maybe have to go for a vertebrectomy, and then only we'll get some reasonable reduction. That point, I don't think I have not heard anybody else discuss that. Apart from that, all the speakers covered everything, and it was very nice to hear about all the talks. I thank you everyone for that, and I don't think anything else to add. And it is a pleasure to be here and hear all these presentations. Thank you very much.
Thank you, Dr. Sandesh. There are a few questions on the chat box. Does the iliolumbar ligament play a role? Would Dr. Akshay like to answer that? Dr. Akshay?
Yeah, hello. Yeah, I'm here. So no, I'm not understanding the question. So what was it? Does the
Does
iliolumbar
the
ligament
iliolumbar ligament play a role? That has been a question in the chat
progression
box.
of listhesis or the development of listhesis?
Yeah, probably.
I don't think it does not have any role as such in the development or the progression of listhesis per se.
Okay.
I don't think that has any major role as far as the
okay.
stability. I mean,
Okay.
there are other factors which are probably contributing, which I have already mentioned in the slides.
Yeah. Okay. Thank you. There is another question. Is standalone back pain not improving with conservative measures and indication for surgery in low-grade diseases? Would Dr. Edmund like to answer?
Yes, sir. So if there is a constant back pain which is not responding to the conservative management and it is affecting the quality of life, definitely there is a role for surgery. If it is not affecting with the quality of life, would physiotherapy alone should help.
Okay. Thank you. One more question is seen. While putting cannulated fenestrated pedicle screw with cement in osteoporotic patient, the cement slipped and caused cauda syndrome post-op. Hence, from there, we use IONM in case of screw and cement. There has been a comment. Anybody would like to respond to this comment? Dr. Sajesh?
Yeah. What I understand from the question is that whether to put the cemented screw or not, I am not very sure. But whatever you do, see, before you do the cemented screw, you have to take a CT scan and see how is the posterior wall is healthy, or it is there is any fracture, or it can come out. Mostly, especially for the fractures, as well trauma that can happen because of some fracture of the posterior wall. If you put the cement inside, it can come out. So in such cases, you should not do the cemented screws. Second thing is you have to do it under the CN guidance, and as you inject the cement, you should watch the cement flow very closely, and if the cement is coming up to the 2/3 of the vertebral body, you should stop. You should not inject further cement in it. And if you have seen the cement is coming out and getting into the canal, definitely you have to go for a laminectomy and take the cement out, or decompose the coda equina or dura or the roots. That's all we can do for that.
Are there any further questions from the participants to our speakers or panelists? Any further comments or questions? Okay, thank you. I think we have had an excellent session, very scientific and thought-provoking session, dealt with by the real experts in the field. I have to thank all the speakers and the panelists for spending so much time for NSI webinar. Thank you so much. And thanks to all the audience and participants who have taken pains to come to this webinar. Thank you.
Thank you, everyone. Thank you so much.
Thank you.
Thank you very much.
Thank you, sir.
Thank you so much.